right, good afternoon, everyone. Thank you so much for this wonderful honor to come and address the TiE group. Growing up here in the Bay Area, I'm very familiar with many of the founders and the various innovations that have been made. We certainly are at a very important time. I come here on behalf of the administration. I'm the Chief Medical Officer in the Department of Health and Human Services. It is the largest agency. We have a budget of $1.2 trillion, and we are considering all national health policies. I'm specifically in the Assistant Secretary for Health's office, and public health issues matter to us. The reason I agreed to come and speak here today is that it's clear that the worlds are colliding with medicine, engineering, with technology, mathematics, and we're at a forefront right now where medicine's going to change. With the discussion on AI, blockchain, precision medicine, all these things that perhaps one of you in the audience may provide some of the private sector options. But what I really want to talk about is our big #1 health crisis. It's not only a priority in the Department of Health and Human Services, it's actually a White House priority. The drug epidemic, as you all have heard, has affected rural and urban areas in the United States. It is an all-hands-on-deck effort with the private sector and the public sector. It isn't just us at Health and Human Services that are considering this. It is the DOJ, the State Department, the Department of Transportation, and various other entities. It has affected those who are the most vulnerable amongst us, but it also has affected those people right here in this room. I spent the last 15 years as a faculty clinical associate professor at Stanford in this very realm, both in anesthesia, which is crisis management, life-saving endeavors, thousands of patients, but also in the Stanford pain clinic. I just want to know here, has anybody ever known anybody to have pain? Just a show of hands. Okay. Pain is a really generic term to describe a very complex neurologic mechanism. It spans multiple diseases, including multiple sclerosis, fibromyalgia, phantom limb pain, post-stroke pain, your bread and butter radicular pain, disc disease, all kinds of things. And it's one of the players in the opioid epidemic, and that is my background. I've taken care of people who are homeless at Stanford and also CEOs, some of which are here. And what I've learned is that this doesn't spare anybody, not just the pain crisis, but the drug crisis. The opioid crisis right now is the largest the United States has ever seen. When we think back to the 1980s, cocaine, does anybody remember that era? It was a very different animal. We had clean products coming from the south of our border. Right now, we're having products that come from China and our postal service. Fentanyl, which is 50 to 100 times more potent than morphine. Something that I use in very controlled circumstances, that it's out there laced in the pills in the illicit market is very concerning. The issue is not just the licit use of prescription opioids. It's the illicit use that is rampant. And I also know that here in Silicon Valley, it's not limited just to opioids, which you see in San Francisco being shot up in day. But it's also LSD, mini dosing, methamphetamines, cocaine, all kinds of things. So it doesn't spare any of us. I just wanted to provide that framework. My background's in molecular and cell biology and economics. I have been in this realm on leave from Stanford to address this very issue, which is my expertise. And my hope is that the private sector, with the new initiatives that we've released from the Department of Health and Human Services, may help provide some of the solutions. Secretary Azar, who is the Secretary of the Department of Health and Human Services. I'm sorry? Oh, yeah. So basically, he came out with just fresh off the press to the World Congress this week, items that I thought were very relevant. So we just put that in our slide deck to include it to this very stakeholder audience. #1, a focus on value-based transformation of our healthcare system. #2 is combating the opioid crisis. Number 3 is addressing the cost and availability of health insurance. And number 4 is bringing down the high price of prescription medicines. The Office of the Assistant Secretary for Health, we are the point people on the opioid crisis amongst all other public health endeavors, such as the flu, women's health, minority health, sickle cell disease, you name it. We're looking at it from a broad population-based perspective. That's where data comes into play. We all hear about data science. Well, this is where we want to utilize it to understand pattern recognition and identify trends. We know that this year was a very tough year for the flu vaccine. It went late into the season and there wasn't full efficacy. But those are patterns that we're identifying and mobilizing what we can do at the national level. But really, it filters down to our private sector. And that is perhaps where I think many of you with your background and expertise could come and help. Dr. Giroir is the Assistant Secretary for Health. He was just finally confirmed after 2 months. He comes with a background in pediatric critical care. He's the first physician to lead DARPA, the Defense Research Program, and he has taken a keen interest in not only the opioid crisis, he's now the point person, and he's my direct boss. This is what we're working on every single day. This is a picture with me and Francis Collins. Dr. Collins is head of NIH, the National Institute of Health, which also comes within the Department of Health and Human Services. Dr. Anthony Fauci, who's been there in the infectious disease realm. He actually was very much a part of the Ebola crisis, but many others, including the HIV crisis. We are considering this and looking at the opioid crisis as we did the HIV crisis, something that was an unknown, that we were desperate, that there was great stigma associated with, but we knew that we had to address. So HHS, does everybody understand the full organization? Anybody here? Awesome. That's Sherry DeVille there, my good friend, Metagram. So HHS is the large Department of Health and Human Services. The operating divisions of HHS are the agencies that you've all heard of. That's FDA, CDC, SAMHSA, and HRSA. SAMHSA is the Substance Abuse Mental Health. We just gave out another $500 million in grants to help with the substance abuse addiction program of that. So value-based care, these are Secretary Azar's, again, his comments just earlier this week, fresh right out of there. We want to maximize the promise of health IT. And we talk about the promise. I can tell you as a physician in the clinical trenches before I got here, we have high hopes, but we also know that the elephant in the room is that many people feel like EHRs actually impeded clinical workflow. And the truth is, the only way to solve that is really with you guys. 900,000 physicians and that many more providers in general are looking to have you help us so that we have time and resources to address the most complex issues in this day and age at a time where we expect it. We all vary in our genetic makeup. We've all grown up in different environments, have a different set of beliefs. Each person in their own right, we could study for the next 50 years to understand better. So we need programs that actually help us, and I think some of the panel before, it sounded like that's what they were talking about. And what I'm here to tell you, and I'm here on behalf of the patients of the United States, who are the patients of the United States? It's all of you. Everyone here, whether it's prevention and wellness, or whether it's actual disease. Here to implore you to consider something far beyond than trying to get the next startup funded and then sold. I mean, Silicon Valley has this great reputation, but we're also concerned about data privacy, right? We have a lot of interesting things. I think things are within grasp, but we need those clinical assistant tools that will allow us the very deep-rooted education that we have with anatomy, biology, chemistry, organic chemistry, physiology, immunology, pathophysiology, and years of specialty training, but we just need that help. So that's one thing, maximizing that promise of health IT in all its forms. EHR is just one. Improving transparency in price and quality. I'll speak about that in a minute. Pioneering bold new models in Medicare. Removing government burdens that impede care. That's key. That's something actually that's throughout our administration, is to deregulate those burdens that go against common sense. Things that only increase the bureaucracy and the inability to actually get to the outcome. Because at the end of the day, what is it all about? What do we all hear about? It is about patient outcomes. The research has to translate. The policies that we're making have to translate. The health IT has to translate into better patient care, and that's what it's about. If you lose sight of that, you lose it all. And none of us are away from this. All of us in this room have a family member, a child, a friend, someone who's in the healthcare system. Most people come out very frustrated. Well, we as providers are frustrated. I can tell you that. We're looking towards you guys. That's the private sector. Health IT, so helping us to remove those regulation burdens to enable better care. New technologies made it possible for the government to focus on not how the interoperability, but the what, right? What does the interoperability do? So we need to be beyond that. That discussion is still there is interesting and amazing to me. I've been using a certain EHR since 2009 at Stanford. I'm intimately very familiar with the challenges. It's great when you want to pull up something, but there's a minutia of data in there, most of which is useless. Okay? We need help with that. Patients ought to have the right to access their data. Who here is in favor of that? Okay, so that's an easy win. Let's figure out how to do it, and also keeping privacy. Because your health data is your most intimate, most important aspect and can always be utilized in a negative manner. And I know you guys know that because you don't have to think, you don't have to hear it from me, you think about it for yourself. What would you want? You don't want people accessing that data. We have HIPAA laws for a reason. Reducing the regulation burden on healthcare professionals. In 2017, CMS pared back regulations that will save providers about 4 million hours of paperwork. I mean, the bottom line is this, we need to not be specialized data entry specialists, but rather have and utilize technology in a manner that helps us get to the bottom line and the tools that we need to help determine where we're going with this. We also did away with some of those, quote, quality measures that were meaningless, quite honestly. That was a joke everywhere. I've been speaking at multiple medical organizations across the nation. Neurosurgeons, rheumatologists, anesthesiologists, pain doctors, National Hospice on Palliative Care. Everywhere. I was just in Vancouver, American Academy of Pain Management. The issues are the same. Everybody is asking for that. I don't think physicians have ever been this unified, ever. They're all about turf wars, okay? So really, it's a mandate. And it's a mandate because you would immediately impact patient care in a manner that I don't know if tech really gets that they can do it in such a substantive manner. My Health eData. Basically, this is an initiative that was just announced to aim to put patients at the center of the U.S. healthcare system. And putting the health data, the very important, precious health data in the hands of the patients. Administrative-wide initiative, this is. And the hashtag is My Health eData. That's fresh off the presses, folks. Blue Button 2.0. Basically, CMS also calls on all health insurers to make data available to patients, and not in a manner that it's hidden, which it's supposed to be available, but really to make it easier to understand and see. That's price transparency. Using open APIs to give patients the ability to connect their Medicare data to apps developed by private companies. I thought you guys would love that, APIs. Like, I know that when I was driving in Uber, I was being driven in Uber, love Uber, and on 237, and of course there's Google Cloud, and what do I see in the windows on the way over here? I love APIs. And I was like, yes, I think the audience is gonna get this, yeah. So these are again, recent statements and releases. This was from the Datapalooza conference in Washington, D.C., the week before last, from CMS, our administrator. So new ways of thinking. I think this is what we're all about here, right? We're about collaboration. I personally believe in a win-win situation. I don't think the zero-sum game actually is viable. And I think that it's always proven to be a loss. It's a loss in that you sell your soul and you crush someone else, but more important, collaboration between all the various different fields in STEM, or maybe STEAM, right? Science, technology, engineering, art. art therapy, yoga, meditation, that aspect, and math. Analytical abilities to collaborate across fields to bring together the very best in medicine. We're on the forefront. We are on the forefront right now through various Cas9, I don't know if people here are familiar with CRISPR, ability to gene split and actually start to get solutions to diseases we weren't even sure we could ever do. I mean, the human genome has been mapped. And at NIH, the pain consortium I attended not so long ago, we were talking about these very issues and initiatives. And of course, IT and data is all going to be there. That's all data science. Data are not perfect, we know that, but the Secretary Azar just announced that they're releasing Medicare Advantage encounter data to researchers for the first time. This is big news. Data, again, may not be perfect, but it's felt that there's a value for the researchers to derive benefit from this. Opportunities for physicians and providers to rethink how they deliver care, and business opportunities for payer or startup company to better coordinate care, to use that data, again, to identify trends and recognize patterns from a larger scale, and then, of course, go and be specific. When it comes to the opioid crisis, we know that it affects West Virginia, Ohio, Nevada, Arizona, California, you name it. Nobody is left out of it. But you know what's really interesting is each of these states have communities that have their own demographics and have a lot of their own reasons for going where they're going. A lot of them have lacked economic opportunities. The Appalachian area, the West Virginia area, hardest hit by the opioid crisis. The numbers are staggering of fatal overdose deaths and near deaths. Why is that happening? Well, they've been sheer out of luck in terms of jobs. There are also social determinants. I know here, I've treated people here from a variety of the large tech companies who come to my clinic with anxiety, depression, and inability to cope with it. Not having coping skills, not having the tools for interpersonal understanding and relationships. So what drives us to these drugs, for example, are varied on where it is. In rural West Virginia, it was something different than the Silicon Valley guys, young kids who are amazingly talented, but are actually driven to drugs for a different reason. And again, that Uber driver friend of mine, he just told me he was sick of it. In San Francisco, where all of us amazing data innovation hubs are opened up from across the nation. Everybody's sending people here because they're smart too. But yet our streets have homeless people at record numbers, many of which are in open sunlight, injecting drugs. And not all of these people are just nothing. There are people who have gone into despair. And I'm giving you the grim view not to depress you, but to motivate you to see that in order for our society to have the greater impact that I know all of you really want here, you have to start locally. You want to change the world, you change the world that's here around you. And then start to help us understand what the greater patterns are across the nation. It's all hands on deck for the opioid crisis right now. It is something that I've never seen, but I've been detecting for the last 10 years with this sense of hopelessness. So we now feel like we have hope, okay? Because we are deregulating, putting the data out, and we're here, so we have hope now. But I will tell you that was tough to watch. NIH has a new All of Us initiative. Basically, the National Institute of Health, as you know, is where a lot of the grant money comes for clinical trials, basic research, basic science, the very stuff that not only addresses immediate goals, perhaps of like curing sickle cell disease maybe in the next 5 to 10 years. Does anyone know what sickle cell disease is? Yeah, it's like where you have a vaso-occlusive crisis when you have triggering events. There's not been much change in this arena, but we're close to it. All the way from something like that to non-opioid alternatives to pain medicine, to bringing together amazing devices that can actually help with addiction, understanding addictions and neurobiological disease, that there are various determinants to it, but that we understand prevention, we understand treatment. Gathering data on everything from lifestyle nutrition to genetic and health outcomes. And that's huge. Isn't that what we're talking about with apps? Will provide unprecedented levels of information about the determinants of health. That's what we hope, to explore new frontiers of prevention and treatment, and for Americans of all backgrounds. The Office of Minority Health, the Office of Women's Health is in in our Office of Assistant Secretary for Health. So is the President's Council on Fitness. What we also are identifying, and certainly a personal interest of mine, because I have 2 elementary age kids, and devices, anxiety, depression, they're linked. We need our kids to get out and start thinking about running around and spending time outdoors. Because at the end of the day, and I'm going to use my example here, because my kids love orcas. Does everybody know what an orca is? A killer whale, right? So my kids love them. They're super highly intelligent mammals in the sea. So my kids love them. We watch them on YouTube and all that sort of thing. And I asked them one day, I said, if there's an orca that leaves its pod and is hovering over a giant iPad all the time, would that be a good thing or a bad thing? And guess what my kids said? I mean, after years of me trying to get them to stop using their devices, they're like, Mom, that would be a bad thing. Because the orcas, you know what? They are very intelligent hunters, and they learn from their pods, and that would be a bad thing, Mom. Well, guess what? We are also social creatures, part of the animal kingdom. But yet we have even more with us. Our cognitive abilities, our neural networks, what we can do is unbelievable. The very vast life experience that we have, in a second blink, we make a decision. And that's not just what is instinct. It's our amazing neural networks. And yet we know that we have a generation that is very privileged to have these devices. Oh my God, just to look up Google and say, hey, what did Benjamin Franklin do? Or, when did, I don't know, Subaru start their first car, whatever but they also, we need that balance. We have to ensure that the next generation has that balance. It's not an either or, it's a win-win. You can have information, but you need to be out there and doing what you do. And that's something that we're putting, fitness.gov. Data science at NIH, developing an overall NIH vision for data science and coordinating across all 27 institutes within NIH and centers in support of biomedical research as a digital enterprise, developing a strategic plan for data science, and dedicated to harnessing the potential of the computational and qualitative sciences to elevate the impact and efficiency of biomedical research. That's what it's all about, the impact and the patient outcomes. Oh, and hopefully you guys saw that. I think it's datascience.gov or something. Data.gov, there you go. The home of the US government's open data. Data, tools, and resources to conduct research, develop web and mobile applications, and design data visualizations, and much more. This is amazing. But you guys are all gonna have to, meet that challenge. Put Silicon Valley in the light that it was meant to be, which is part of the solution. Work with your other STEM partners, the science, whether it's the clinical physician or the social worker or whomever, and all the rest of it, and bring it together. It was meant to be. CDC's unique work, I'm going to just take the last couple minutes here to give you a sense of what we're up against in the opioid crisis, because this is our immediate need across the nation, and it really doesn't spare anybody. For every one prescription or illicit, which is illegal, opioid overdose death in 2016, there were 15 people who reported having a substance abuse disorder involving heroin. Heroin's become super cheap. 41 people reported having a substance abuse disorder including prescription opioids. 200, almost 300 people reported misusing that prescription opioid in the last year, and over 2,000 reported using prescription opioids in the last year. So for every one death that you hear, there is an iceberg beneath it. Prescription opioid misuse is decreasing in that we know the number of prescriptions are going down. The president has set an initiative to decrease the number of prescriptions by a third in 3 years. But we also don't want to leave those very patients, the carve-outs, the subpopulations that actually do well, that aren't addicted, that are actually functional, that have had their lives changed with it. So as we look for new opioid molecules that help with the pain relieving quality but don't have the respiratory depression side of it. Pain in the US, about 25 million American adults who have pain, not just chronic pain, which is defined as having pain beyond 3 months, but have it every single day. So this is an underestimation of the chronic pain patients. And like I said, chronic pain is a very generic term that doesn't describe actually what is really going on. There are neurologic mechanisms that are so complex. We have a 5-point strategy at the Department of Health and Human Services: better addiction prevention, treatment, and recovery services, better data, public health data. 3, better pain management. That's my background, that's my expertise. I've devoted my life to this, 17 years now. Better targeting of overdose reversing drugs. The Surgeon General just came out with the first advisory from the Surgeon General about naloxone and having it not only available for first responders, but family members who are on opioids. And then finally, better research. I'm the lead on the pain management task, interagency task force, and we just announced our members were having our first public hearing meeting on May 30th, 31. We have a congressional mandate to, with the DoD and the VA and the ONDCP, which is the drug czar, to come up with a review of best practice clinical guidelines, gaps and inconsistencies that exist currently in the non-opioid realm. And let me tell you, I have fought with one insurer or another for years about things that we know exist, to address that and get that out there with a report to Congress. This is happening now. It is a broad group of people, leave it to Congress asking us to include everybody, and somehow I'm going to be chairing this. So physicians, dentists, non-physician prescribers, pharmacists, pharmacies, pain research, addiction research, pain management professional organization, mental health treatment community, addiction treatment community, patient advocacy groups, veteran service organizations, very important, overdose reversal, state medical boards, hospital associations, et cetera, and of course the minority health folks. We also have a national pain strategy, just giving you a sense out here. It's the first federal effort to address pain from a professional education, public education, disparities, prevention and care, services and payment, and population research. We have a behavioral health coordinating committee. I just met a gentleman who just gave me his work that he's doing on cognitive behavior therapy, which is very essential to this. And this is the private sector. I just met him, right? Is it Marius? Marcus. Okay, so Marcus just told me about Teatros, resilience within reach, and he's talking about mental health opportunities. We need to do this. This does not leave anybody out of it. Everybody here, whether you admit it or not, knows a friend or a family member who has mental health issues of depression, anxiety, or something else. And we've got to integrate that into the primary care arena. Interagency Pain Research Coordinating Committee. This is $81 million just allotted to DoD and VA to look at specifics. Our veterans, they come home from fighting. They have post-traumatic stress disorder and all kinds of other issues. They've lost a limb, so they have phantom limb pain. They have a tremendous challenge. We're looking at that, also with our active duty soldiers. And then finally, the NIH Public-Private Partnership, explore ways to promote safe, effective, and non-addictive strategies to manage pain. A lot of these things seem redundant, but they actually have very narrow charges to look at specifics of it. And these are being done and initiated at a very large level. In the recent omnibus spending bill, huge spending bill, we did get money allotted to fighting much of this cause. How you can help: bring public awareness, resources, help your friends, take away the stigma, encourage treatment, help them get through it. This is our society. We live here, and we got to make sure that we keep our society the way it is. Connect end users with resources, warnings, anonymous help. We have all kinds of national helplines. We have the substance abuse mental health. And there's a lot of interesting resources out there. The problem is the gap in who's really looking at hhs.gov every day. It's super important, but who really looks at it? I was at Stanford. This is my expertise, and I didn't know the initiatives that we had. And that's okay, because life is very busy. But part of my job is to close that gap, bring us all together, connect those dots, and hopefully we have an outcome. And I'm really out of time. So I want to thank you all. That's my email address, my Twitter handle, at CMO HHS. That's Chief Medical Officer, Health and Human Services, and at Vanila Singh is my own personal Twitter. I don't do this to be out there, but rather really sincerely have treated the most amazing patients who continue to inspire me, who I promised them that I would come to DC on their behalf, and hopefully in whatever time we have to make that difference. And I greatly appreciate all your help and your initiatives. Thank you.